Yeah. Good evening, Young Turk. So welcome all the Young Turk. So this is the program of Young Turk for the Young Turk by the Young Turk. So greetings from IFS. I am Dr. Neeru Thakral, your national coordinator for this Young Turk activity. So we are going to start this and we are doing it every second and fourth Friday, 7 p.m. Anyone who is interested in research, presenting a good topic, journal, maybe a clinician, maybe embryologist, you can contact me or Dr. Nisha, and you can send us your choice of 3-4 journals and we can finalize in one of them. So today we have our expert, Dr. Lavleen Sodhi. Dr. Lavleen Sodhi is from Chandigarh
Yes.
Regional IVF Center. She's a past president of Menopause Society, secretary of Greater Chandigarh and chapter of IFS at present. Welcome, Dr. Loveleen. So today she will tell us how to select a good topic for the journal. After that, we'll start the journal club. Yes, Dr. Loveleen.
Hello, everyone. First of all, I think it is just an absolutely amazing idea to have this platform where the youngsters, we can nurture them to take part in research, give them the confidence to do that, and cultivate their skills. And I think Dr. Neeru, you're doing a great job.
Yeah, welcome, Dr. Shweta Mittal. Actually, this program was vision of our president, Dr. Pankaj Talwar and Dr. Shweta.
Yes, sir.
We definitely want all our young Turk to do research. Go ahead. So welcome, Dr. Shweta. Yes.
When we when we want to select a topic for a journal club, so first and most important is it should be a topic which is of interest to most people, and it is something practical. So things which in your day-to-day practice you feel baffled or uncertain about how to deal with them. So that is the kind of topic which will be of interest to most people and should be discussed at length and should be taken for a journal club. Second thing is definitely it should be from a good peer reviewed journal which has a good standing, and the authors also, if they can be those, I mean, if it's an original research article, that is always better rather than a review article. Original research article from a journal which has a good impact factor is what should be done. Then another thing is that very long articles sometimes will get boring. So even in your presentation, you should be concise and keep discussing the important points rather than lingering on every single point which is there in the article. So keeping it brief, keeping it crisp is very important, like in any other presentation, not just a journal club. Keeping the discussion brief and crisp is also extremely important. And yes, one more thing is it should be a relatively recent article. I mean, there is no point in taking up an article or a paper which is old. So if as recent as possible is also important, though of course it should fit into the other criteria as well. So in that particular subject which you are taking, whatever is most recent is always the best thing to be done. Anything else that Dr. Neeru you would like to add?
You have beautifully summarized everything, short and sweet. I think Dr. Shweta is not here, na? So we can invite now Dr. Thank you,
Dr.
Dr.
Shweta is there.
Yeah, she want to say anything? Okay, then otherwise we'll invite Dr. Suhani Chandra for the excellent topic. You can screen share Suhani. Dr. Suhani Chandra is from Lucknow and she is speaking on very excellent topic, future perspective of Poseidon stratification for clinical practice and research. Yes, Suhani.
Thank you for the introduction, ma'am. I'll just share my screen.
So you all are also welcome to present any presentation, maybe clinician, maybe embryologist. You can just message Me or Dr. Nisha?
Good evening, everybody. Ma'am, with your permission, may I start?
Yes, yes, please.
Is my slideshow visible clearly, ma'am?
Yes, yes.
Good evening, everybody. Thank you, ma'am, for giving me this opportunity and this platform to present this article. I'm Dr. Suhani Chandra. I just completed my diploma in reproductive medicine and surgery from Sir Gangaram Hospital. I was under Dr. Shweta ma'am for 1 year, and I learned a lot from her. And again, I want to thank her especially for creating this platform for us youngsters to come forward and present articles. So today's article that I'm presenting is actually a mini review on the future perspectives of Poseidon stratification for clinical practice and research. This was published in July 2019 by Dr. Peter Humidian, Dr. Antonio Lamarca, Dr. Alvigi, Dr. Estevez, and Dr. Thor Hart, all the stalwarts in the concept of Poseidon and low prognosis patients in IVF. So this mini review actually focused on discussions on the clinical implication and the purpose of implementing the entire Poseidon stratification. Almost 50% of patients undergoing IVF treatment as of today fulfill the Poseidon criteria. And these Poseidon patients share the same characteristic of having a low ovarian response to exogenous gonadotropin stimulation. They require focused attention regarding their ovarian stimulation. And the key to success in all these patients is individualization in all steps, be it their ovarian stimulation, their gonadotropin dosing, or their embryo transfer. This Poseidon criteria was created to address the heterogeneity in the Esri-Bologna criteria that was initially established. And this Poseidon criteria now has a more homogeneous subpopulation. It takes into consideration the age, the ovarian reserve, and previous ovarian responses. It has been set so that in order to guide clinicians and to set patient expectations as well. The clinical recommendations for type of GnRH analog to be used, the gonadotropin type to be used, and the dosing are going to follow in this article. The ultimate goal for these Poseidon low prognosis patients are to get a good number of oocytes for one euploid blastocyst transfer. So as we are familiar, the Poseidon stratification stratifies low prognosis groups into 4 categories. Group 1 and 2 are patients with adequate ovarian reserve. The only difference between these two groups is the age, less than 35 years and more than 35 years. And these patients are patients who have already undergone a previous OS cycle where the number of oocytes retrieved were either suboptimal or low. And group 3 and 4 are poor ovarian reserve patients who can be either less than 35 or more than 35 years old. Following the establishment of the Poseidon stratification in 2018, Alvegi et al. Came up with the follicle to oocyte index as a new marker for understanding the ovarian hyporesponse to exogenous gonadotropins. This was basically a marker of ovarian sensitivity to gonadotropins, and it was a ratio between the total number of oocytes collected at the end of the ovarian stimulation to the number of antral follicles that were available at the start of stimulation. Less than 50% is considered a low FOI. Less than 50% of the number of antral follicles that were there giving oocytes at the end of a cycle is considered to be a low FOI. Then came the concept of an ART calculator that was developed, again, based on the Poseidon stratification by Estevez et al. In 2019 to predict the number of oocytes that would be needed, particularly in these low prognosis groups, to achieve at least one euploid embryo for transfer. The overall idea of the Poseidon stratification till date is to first guide clinicians for clinical management, and second, very importantly, to serve as a counseling tool to set patient expectations. Now, coming to the future perspectives for daily clinical practice, how does the Poseidon stratification apply to our daily practice? The first is it should guide as a daily tool to identify whether an individual patient fulfills the criteria of being a Poseidon patient, and if so, which will happen in at least 50% of patients, to which of the four subgroups can the patient be divided. After this comes the individualization of ovarian stimulation protocols as per the patient category. Now, these are certain best practice guidelines that have been outlined in this article that tell us how to go about handling each group of the Poseidon patients. In group 1 and 2, where there is a good ovarian reserve, where the AFC is more than 5 or the AMH is more than 1.2, and the patient may be less than or more than 35 years of age, the general recommendation by the Poseidon Committee is to go ahead with an antagonist protocol only. Further, the ovarian stimulation strategy, the first choice should be an increase in the daily recombinant FSH dose by 75 to 150 international units. And in those patients in which in the previous cycle, there was a stagnation of follicular recruitment in the size of 1 to 12, where the entire cohort got stagnant between 1 to 12 mm. In those patients, they have added that we should consider adding recombinant LH 75 to 150 units from day one itself. And this stands true for both group 1 and group 2, that is irrespective of age. In Poseidon group 1 and 2, these two recommendations stand true. Then comes the trigger or the retrieval strategy. The choice of trigger purely depends on the embryo transfer strategy, whether we are going to go ahead with a fresh or a frozen transfer in these patients. It can be an agonist or an HCG trigger. In terms of, so once we have the oocytes in hand, once we have done the pickup, then comes the role of the ART calculator and the FOI, or the follicle to oocyte index. So if there is a low FOI, that is the expected from the AFC, when the number of expected oocytes are less than 50%, then the next strategy is to consider increasing the dose of FSH further, to consider the timing of retrieval, should that be changed, and to consider a dual or a double trigger. Further, in such patients where the expected number of oocytes has not been attained, where the oocyte number is low, we can also consider pre-treatment using short-term estrogen or progestin therapy, or even 12 to 14 days of OCP for synchronization of the follicles prior to stimulation. The next is if the FOI, the follicle to oocyte index, is fine, it's more than 50%, but the overall number of oocytes are insufficient according to the ART calculator to be able to provide us with one good euploid blastocyst. In that case, we can go ahead with an embryo accumulation or oocyte accumulation strategy, and we can counsel the patient for a duostim. Ultimately, the goal is for one single blastocyst transfer. So having talked about group 1 Poseidon and group 2, the main difference is the age, which makes a lot of difference in terms of the oocyte quality. In group 1, the patients are younger, less than 35 years, and they have good oocyte quality. So the number of eggs required for a good euploid blastocyst will be lesser. Whereas in group 2, even though they have a good ovarian reserve similar to group 1, their age is either more or equal to 35 years. In that case, there's increased oocyte aneuploidy, and therefore a much higher number of eggs will be needed to be retrieved in order to achieve one blastocyst. Coming to the best practice guidelines in Poseidon group 3 and 4, the expected poor responders, where the AFC is less than 5 or the AMH is less than 1.2. In these patients in group 3, especially where the age is less than 35, but the AMH and AFC is low, this would include either a long GnRH agonist downregulation or a primed antagonist protocol, meaning that there is co-treatment or a prior treatment with short-term estradiol varenicline or progestin pre-treatment or an OCP pre-treatment. Along with that, the committee has recommended use of adjuvant treatment, including androgens, growth hormone that can be started either prior to stimulation or along with stimulation, and CoQ10, the role of CoQ10. In group 4, there is a dual negative effect of a reduced ovarian reserve as well as the age, and this increases the chance of aneuploidy. The recommendation in these patients also includes GnRH agonist downregulation protocol or a primed GnRH antagonist protocol primed by estrogen or progestin or OCPs. And this should be followed now by a stimulation strategy that includes at least 300 international units of recombinant FSH or corifoliotropin alpha, and in Poseidon group 3, that is less than 35 years. And if the age and the AFC AMH both are factors in Poseidon group 4, then a high dose, that is a maximum dose of 300 plus 150 recombinant LH should be added, and these patients should be stimulated with this protocol. In terms of the trigger strategy, in the long agonist downregulation protocol, HCG is mandatory, whereas in the whereas agonist will be mandatory if we are planning to go ahead with a duostim. So especially in these group 3 and group 4 patients, we have to be ready, because these patients are candidates for duostim. They have to be counseled beforehand that they may be able to go for duostim. So if in case we want to go for duostim, an agonist trigger becomes necessary. So in a long protocol, HCG trigger, antagonist protocol, we can use an agonist or an HCG trigger, and for duostim, an agonist trigger only. Again, we evaluate the FOI and the oocyte number. If there is a low FOI, again, we can consider adjuvant treatment. We can consider the timing of retrieval and consider dual or double trigger. If there is an insufficient number of oocytes retrieved as per the ART calculator, then again, we can go ahead with the duostim or a new stimulation for the purpose of embryo accumulation. Future perspectives for research based on Poseidon. Currently, retrospective analysis of large databases may match patients so as to fit into one of the 4 Poseidon groups. Most of the research available on Poseidon groups right now is in a retrospective manner. However, it is unlikely that patients were treated according to the recommendations made by this Poseidon stratification committee. Therefore, in groups 1 and 2, the future research, it should encompass good reserve patients, some of whom have the presence of uh, FSH receptor and LH receptor polymorphisms or variant LH beta. Future studies should evaluate the benefit of screening such patients prior to stimulation. And from the findings, the subsequent stimulation should be tailored. Patients with FSH receptor polymorphisms, which should receive an increase in FSH dosing, plus patients with an LH receptor polymorphism or presence of a variant LH beta should be treated with recombinant LH right from day 1 of stimulation. And then further study, the entire study should be carried out. The primary endpoint of these studies should be the cumulative live birth. And the suggested secondary endpoint by this committee is the achievement of the number of mature oocytes needed to obtain at least 1 euploid blastocyst. The future research recommendation in group 3 and 4, the question in both these group 3 and 4 is whether we can increase the number of growing follicles and subsequently the number of competent oocytes. So the first thing to consider is which regimen is the most optimal. The long agonist downregulation protocol, the antagonist protocol with prior priming with daily estradiol, with the antagonist protocol with priming 12 to 14 days of OCPs prior to stimulation. And the second question is, I'm sorry. The second question that arises is, will long-term pretreatment with androgens or short-term pretreatment with the growth hormone before or during stimulation have an effect on the actual number of growing follicles and oocytes? The third investigatory question can be whether duostim reduces the time to live birth for groups 3 and 4. In this study, in this kind of a study design, it should be compared with an agonist or a primed antagonist protocol. The Poseidon stratification has been well accepted by reproductive endocrinologists and infertility specialists worldwide. However, it still needs to be prospectively investigated. Integration of the Poseidon and the ART calculator in daily clinical practice is essential for decision-making and counseling with the aim of providing the most optimal treatment and for reducing the time to live birth. Thank you. Ma'am, you're muted.
Excellent, Suhani. Wonderful presentation, comprehensive topic, very nicely explained everything. It was a clear, I think, for everyone. So
Thank-
we are eager to listen comment by our expert. Loveleen, can you give your expert comment for this? And then we'll start taking question answer.
Yeah. So, of course, the low prognosis patients, the change in nomenclature itself is very nice. Instead of all the time poor reserve, this is now a new nomenclature that they are to be called as low prognosis patients, because not all of them are low reserve. Group 1 and 2 are actually not poor ovarian reserve, but they behave the same way as far as the final output is concerned. So that is one thing. And of course, the counseling part becomes so much more comprehensive and objective, instead of just giving it abstract explanations to the patient. It becomes easier, and especially if you can use the ART calculator, that again is good. And then treatment strategies, all this while I think probably we were doing hit and try. Sometimes you could try this, but now we have a clear definition of this can be done and this cannot be done. And then also for future research, the post-sort criteria, I think they have done, maybe given, maybe in one of the future journal clubs we can talk about the post-sort criteria also, because then research also becomes more uniform. You have the same criteria, same definitions, because definitely all this while, when you say you get a negative result, the negative result can be because of poor endometrium, the negative result can be because of poor oocytes, poor sperm, so many other things. So at least here, keeping the endpoint as the one euploid blastocyst means that you are now talking purely about ovarian stimulation and what embryos you are getting. So
We
I
can take
think
the
there is
question,
a
I
lot
think.
to be derived from this particular paper from that point of view.
Yeah, so we'll start taking Himanshu, please make Dr. Nisha Bhatnagar unmute. And Dr. Shweta video also disabled, so kindly correct it. So question is, ma'am, this AFC count is in one or both ovaries? Yeah, Suhani, can you answer this? Unmute.
Ma'am, this is in both ovaries. For Poseidon stratification, it is in both ovaries.
Yeah, so if you are saying 4 to 5, in that means it should be the again unmute yourself, Suhani.
Yes, ma'am. Yes, ma'am.
So if you say less than 5, that means it's less than 5 in the
Both ovaries combined, ma'am.
yeah. So it's a combined in the both ovaries, less than 5.
Dr. Lovely,
Yeah.
there is a question regarding the recommendation of CoQ. So is there any age specific criteria that CoQ is administered in one particular age and not in the other?
Coenzyme Q is supposed to be good for the oocytes as such, to improve oocyte quality. So it is recommended for the older women with decreased ovarian reserve, but I don't think there is any such age criteria that you cannot give it to the younger women. But per se, you expect the younger women to have good quality oocytes. So as it is, I think we keep pumping our patients with too many medicines. So it makes more sense to give it to the older women.
Yeah, especially after 37, 38 and after 40. Yeah, where we expect the poor quality.
Poor quality. Younger patients in any case will have better oocyte quality.
Yeah.
So I think the most important criteria is age.
For oocyte quality, yes.
Yes, definitely.
Yes.
It's the single most criteria.
Like somebody wants to know that is there any relation with CoQ dosage with age? I don't think so. I think we can supplement CoQ as a general antioxidant for all age groups.
Yes, it can be done, but my only apprehension is that we kind of tend to, give them to, as it is, these patients who are undergoing ART treatments, they are being pumped with so many medicines. So if there is no clear-cut indication, unless if somebody had poor oocyte quality in a previous IVF cycles, then yes, I would look for things like this, addendums.
Yeah,
But otherwise, I personally do not like to give, too many antioxidants, too many probiotics and all kinds of things to all the patients.
Yeah,
Yeah,
definitely.
the market
I
is
would
full of.
also don't like.
Maybe we can make, maybe we can counsel them about the importance of diet, yoga, exercise, and sleep. I think that is the first most thing. Give them some time to work on their body, and then maybe we proceed with other things.
Definitely. Because we
Dr.
don't
Lovely,
want to make
generally
big
recommend
burden.
weight reduction to such patients? And if yes, then how long?
See, weight reduction for an obese or an overweight patient, definitely weight reduction is recommended. But however, you have to see how far you can push a patient. Somebody who's been overweight for years and years, and she's been going from one place to another, undergoing treatments, and then who has never been really been able to lose weight, and now she's kind of in the older age group, closer to 35 or more. So then I would not, I would start off the treatment along with the recommendation for weight reduction. Whereas if it's a younger patient, clear cut PCO, then I would definitely give them time that to go take 2 or 3 months, reduce weight and come back. And during that time also, I tell them, I call them for a follow up at least once a month, so that they are in. I'm watching what they are doing. It's no point they come back after 3 months with no weight loss, or sometimes even little weight gain. So then you have just lost time, and by that time the patient also starts feeling disappointed कि कुछ बन नहीं रहा है ना?
Yeah, but
So
I
maybe
always
careful
give at
observation.
least 2 to 3 months time, because we know with the obese patients, especially BMI is more than 30, we are definitely going to have a poor quality oocytes. So always give at
Definitely.
least 2 to 3 months,
Yes,
whatever
that much
it
time has to be
is.
given.
Dr. Loveleen, there is a question. In dual stimulation, giving only agonist trigger can cause empty follicle syndrome in poor responders. Do you feel so?
I think this was a belief earlier, but now I think many of us swear by the oocyte quality. You get very good qualities oocytes with a oocyte trigger,
Yeah,
and
but
empty
generally
follicle
in
is
dual,
not the
maybe
thing.
in, yeah, generally dual trigger is preferred in poor responders.
Yes, dual trigger is preferred, but it is more to do with the luteal phase support that which may be, a more aggressive luteal phase support may be required. If you are giving only an agonist trigger, luteal phase deficiency may be more marked. But I don't think empty follicle syndrome is an issue.
In dual stim, in the first simulation, we give the agonist trigger. Why? Because we want early luteolysis, so that we can start the second simulation after 2 3 days.
Yes,
HCG
and
we
you don't
take,
have
it
a
takes
choice.
longer time. So that's why we don't give HCG.
No,
We
no,
give.
here they are not talking about dual stimulation. The question is particularly only if a dual trigger or only agonist trigger can cause empty follicle syndrome. Can it or can it not?
No, we do
No.
give an
No.
dual agonist only trigger. If we feel a patient has too many follicles, she's going
No.
towards hyperstimulation, we do give agonist only trigger. I
Only
don't think
agonist.
it
Yes. No,
will
So
no,
lead
she's
to.
nothing.
talking about poor responders. So
Yeah.
I think because we prefer to give dual trigger in cases of poor ovarian response patient, because as it is the yield is low and the maturity of the egg would be better if we give dual trigger. So agonist trigger usually we give along with HCG.
I absolutely understandable, but that will not apply to duostim. If it
Yeah,
is,
because
Yes,
if
we
it
that
is
will
she's
not
not.
a
asking
duostim
about dual
cycle,
stim.
yes, we would definitely prefer a dual trigger.
She's asking
Yes.
about dual stim. So here in dual stim, we give only agonist trigger in the first cycle, first stimulation
Yes.
for the early luteolysis. And we can give then dual trigger in the second stimulation, where we are not worried for the
But
early
it has no
luteolysis.
relation, Dr. Neeru, it has no relation with empty follicle.
No, 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 nothing. No,
Yeah.
not hardly anything.
So any recommendation, we already discussed this one. So Dr. Loveleen, another question in group 3, long protocol. Will it cause too much of suppression of LH?
See the idea behind doing a long agonist protocol for the poor ovarian reserve patients is that very often when you are going to start the stimulation, because of the relatively higher levels of FSH, at the start of stimulation you will find one follicle has already been recruited. So once you have already have one follicle recruited, usually your response will not be good enough. So these that is why if you find this happening repeatedly, it is always a better idea to make the patient go either through a
Long protocol.
pre-treatment or a long agonist protocol. That is the basic idea or fundamental, the science behind this recommendation, that patients with decreased ovarian reserve very often will recruit the one follicle very early on day 1 or day 2. Already the follicle will be recruited, and then your cohort will not be nice.
Yeah,
So
in fact,
for
we'll get
these
very good cohort in these.
so to get a good cohort, it may be it may be better to either do pre-treatment or to give them a long agonist cycle. And like Sohani pointed out, that for future research, we really need to see if 14 days, approximately 2 weeks of OCPs will really do damage or not in an antagonist cycle. So with that, again, you would get a good cohort, but then yes, sometimes they tend to be a little more down-regulated, and then actually there are so many variables in these patients that you really don't know what went wrong. Is it the patient profile per se which was not good, your injections, your protocols, or was it the previous OCP pre-treatment? So it becomes difficult to define. So this is a good area for research in the future.
Yeah,
I think the
earlier we
most
were
important
using
thing in
only
these cases is
antagonists.
individualization.
Yeah, earlier we were using only antagonists, but now again we are starting again long
Yes.
protocol in group 3 and 4. In fact, we get a good cohort. So sometimes we use even stop protocol. We give them agonist, stop that, and then we can convert it to the antagonist later
Yes.
to get the good
Yeah,
cohort.
flare, microflare.
Yeah.
So, Dr. Loveleen, which protocol do you follow if you have to go for dual stimulation? Can you give a brief idea to all?
See, basically, the first stimulation is kind of similar to what you do in an antagonist cycle. So as soon as you feel, usually around day 6, or when you have 13, 14 follicles, then you start the antagonist. And the difference in the first stimulation being that your trigger is going to be an agonist trigger only. And then usually this is followed by a 4 days break, and then after 4 days, after the egg retrieval, you give a break of 4 days, and then you get started with the stimulation again. And when you do the second stimulation, usually the antagonist may be started, or progesterone, like in a PPOS cycle, may be started at the time of stimulation itself. So, and then the second time, the trigger can be a dual trigger or an HCG trigger. It wouldn't matter, because here we are not worried about the prolonged action and the early neutralizers that we would.
So I'll tell you what we do at our center is, for initial day 2's first part of stimulation, we usually do FSH values. If the FSH are too high, I usually don't give any gonadotropins. I either give tamoxifen or clomid, and I take those 1 or 2x, whatever are there. And once I have picked, I again analyze and see how many follicles are there. And if there are 2-3 follicles, I again, depending upon the situation, my response, my number of eggs, I go either with clomid or with HMG. In the second part, we give HMG. This will be a progesterone prime stimulation, because the corpus lutea will serve the progesterone, and it will help us in I usually give gonadotropin in this part. The progesterone act as the antagonist, and first part we give agonist trigger. Second part we give dual trigger. This gives us excellent result. In the first part of stimulation, we usually get 1 or 2x. In the later part, if there are follicles after the pickup, we usually get 3 to 4x. So in total, 6 to 7x and very good blast. Again, individualization is the key.
So you
Yeah.
mean to say in the first stimulation, you do not give them any gonadotropins at all?
Depends upon, if my FSH level is already high, then I don't give gonadotropins. Like if it is already 17, 18, there is no point in giving gonadotropin. Then I just give either clomid, or I just give cytotam or tamoxifen. And I take those 1 or 2, whatever eggs are there. You see, if the FSH levels are very high, usually we see a follicle which is ready in 4, 5 or 6 days only. So once
True.
we pick that, then after giving the trigger, we assess the second part, and then we restart the stimulation. Also, there are 4 stages of low ovarian reserve. We have to characterize with the value of hormones and the follicles that which stage the patient is. and then we have to start the stimulation accordingly. So there is another question here which says that which expert team opinion about role of intra-ovarian PRP? Have you done, Dr. Loveleen?
I
You
have
use that?
I have done a few cases in where the ovarian reserve is very poor. The patient is not willing for donor oocytes, and we have no other way forward. But to be honest, I
Yes.
have not found any amazing result.
I agree with you
Yeah,
totally.
no, I
We
have
also did in
used,
2-3
and
cases,
I
but
got good result in few patients also. We
I
used,
think
okay.
it is the younger patient with the decreased ovarian reserve who may
that's
still respond. Whereas the older patient with poor reserve, closer to 40, beyond 40, they I think nothing works for them because they do not have
right.
anything left in the ovary which will respond.
Sometimes like we get good response. It's not that every time we'll get, but yes, sometimes we have got good result
I
also.
am still waiting for that time for myself.
I agree with you, Dr. Loveleen. I have also not seen good result. We have done PRP. Rather, I saw a research paper on use of Gonal-F. Like, after pickup, they were pushing Gonal-F, like recombinant FSH, into the ovary. They said that the yield was better. Instead of FSH, instead of PRP, they were, giving Gonal-F. But we have not seen. Again, well, you rightly said it is the age. In the younger age, we do see a good response, but in
Yeah,
the older age group, usually the response
definitely,
is not there.
definitely.
There's
Age,
another question.
what is
Would you
the,
like to take that?
Yes, go
How to
ahead.
proceed with the agonist protocol, stop, and then antagonist protocol?
This is the stop protocol what Dr. Neeru was already saying. So I don't really use it very frequently. But what I understand is or that you start the agonist like in the mid luteal phase of the previous cycle, and when she gets the period, you stop it. So, and then you do the regular stimulation and an antagonist cycle like you would do anywhere else. Dr. Neeru, would you be able to tell us anything more?
yeah, we use it in the poor responder and sometime in PCOS also. PCOS, if we have very high LH and we want to suppress the LH, then also we use the long agonist. And after the day 2 of the cycle, we stop the agonist and convert in the antagonist. Because in PCOS also, we don't want to use agonist because we want to give agonist trigger also. So we want antagonist protocol. From day 2, we take it as the antagonist protocol. We give only gonadotropin and antagonist is started at 13 and 14 mm. And in poor responders also to get a good cohort. Many times if we see day 2, yes, this time patient is having very 2-3x a heading, 1 hour small. So next cycle we take her for the long agonist protocol. So get a good cohort and we can then stop also on the day 2 and convert it into the same antagonist protocol.
Nice, very nice. So, Hani,
So,
I think we are running short of time. Is there any other question we need to take?
May
The
I ask,
four stages
5-10
of
minutes more. Yes.
may I
Okay.
ask one
So the
question?
4 stages of low ovarian reserve, it's a lecture in itself. We need at least 30 minutes for that. Maybe we will have the permission of Dr. Shweta and Dr. Pankaj Talwar sir, and we will organize a lecture on that.
If
So
you
Dr.
want, you
Sohani,
can
you did a,
summarize, Anisha, in 5 minutes. You can give the little inputs about that to them.
yeah.
We
So
have,
I would request Sohani to give the take home messages, please.
yeah.
Yes, ma'am. So, from today's article, the recommendations by the Poseidon stratification group, first thing is to incorporate the Poseidon stratification and categorization into daily practice, whether a patient belongs to group 1, 2, 3, or 4 of the Poseidon criteria. And the second step is implementing the strategies that have been recommended by the group in the respective criteria. The third thing that they emphasized on is the need for further research in terms of validating which strategy works best for which group of patients.
Yeah,
Nice,
nicely
nice,
summarized, and your presentation was also excellent.
very
Dr.
wonderful.
nice.
Naveen, in
Well
your
done.
practice, which gonadotropin you are using in these patients? You are using HMG or you are using FSH, Gonal-F? Which gonadotropin you are using in this poor
I
responder?
use recombinant
Especially,
FSH. in almost all my patients, but group 3 and especially group 4 they are the ones where either I add recombinant LH if the patient is affording because it becomes expensive,
But nowadays
or
we are not
otherwise
getting
I add
LH.
HMG. Otherwise, I like to, by and large, I like to add HMG for the group 4 patients, especially if I'm going to, from day one of stimulation.
Yeah. We also, in the group 4 patient, always like to have HMG only. And we are not getting nowadays recombinant LH. Luvaris is short.
Okay.
So they
I
are not
use it
giving
very,
us.
very sparingly because it's too expensive. And
Yeah.
especially
We
these
also
ovaries,
use,
there's nothing in them. You just,
Yeah.
yeah.
sometimes I feel that maybe we should just give them clomiphene or letrozole along with HMG and
Yeah.
stimulate them. Still, you will get only 2 follicles and 1 or 2 sites. You give them a huge number of fancy
Hormones.
cytotropin, you still get 2 sites.
Yeah, I'm also combining them with the oral ovulation, either clomiphene or letrozole, and sometimes both clomiphene and letrozole. So I'm using only hardly 225 HMG with them. So we are
Okay.
getting
I'm
good
using
response.
only oral, only Clomid or only,
Yeah.
I use 100 milligram of Clomid throughout the cycle. I don't add gonadotrophins. And Dr. Loveleen rightly said that it, saves a lot of money for the patient. And at the end, the patient is getting 1 or 2 those follicles only.
And
And
you're
worst
not
case
using,
scenario, even if we need to cancel the cycle, the cost is not the
Not,
problem there.
yeah,
not
so you're not using antagonist also because you're using clomiphene only, na? That will act
I
as
am
antagonist.
using oral antagonist. Like I am using modified luteal phase stimulation. I use either Dufeston or Meprate along with Clomid to act as the oral antagonist.
Yeah, definitely. And
Well,
clomiphene
very
also,
Uh,
interesting. Dr.
if we are
Nisha,
giving clomiphene, we also don't require antagonist. It will act
yes.
correct if we are
Dr.
giving
Nisha, do you
continuous.
have some papers to back up what you're doing? What you're saying is very interesting.
Yes. Yes,
Uh,
I can share with you.
I would be very glad if you could share with me because these patients are
Sure.
the ones you feel very bad
Yes.
to cancel the cycle or just 1
Yeah.
or 2 sites, one or
Yes.
maybe no good quality embryo. So if the patient has not spent too much, it is still justifiable. And what you are saying is very
Yes.
fascinating that you do just the oral drugs first
Absolutely.
and then you give. I mean, I think it would be worth trying.
Yeah.
Yeah.
So
I
do share
think
that paper with us.
will sure definitely will do. Thank you, Dr. Loveleen. Thank you so much for taking out time from your busy schedule. And as usual, I'm really, really thankful to Dr. Neeru ma'am. She is like, our pillar of strength. Whenever anything is needed, we go to Dr. Neeru. Thank you so much to Dr. Shweta and Dr. Pankaj Talwar, sir, for giving us this platform. So, Hani, your presentation was excellent, to the point, brief, summarized, and, very, very well presented. I also would like to thank BSV for becoming the academic partner for Journal Club and encouraging the young minds to explore and come out with new ideas. Thank you so much. I would love all of you to, come out with your topics of interest, and then somebody amongst you can choose to present. Thank you so much.
So
Thank you
we
so much.
want
Just 1 second, we
embryologist
have few
also can
messages.
present. Yeah. Instead
Yeah.
of clinician,
So Dr.
sometimes
Dr. Loveleen, I'm sorry we ended, but somebody wants to know about low dose HCG protocol.
Low dose HCG protocol, I'm not aware of.
Okay. So
no,
this is
here
very
we are
micro
using
dose.
150. Here we are using 150 to 200 units of HCG daily. So here also we can use only with the oral Ovigen plus HCG. So we don't use any HMG. We don't use any gonadotropins just to cut short the cost of the patient.
Okay.
Dufeston dose is 10 milligram BD. Okay. With this, I would like to end the meeting. Thank you, BSV. Thank you, IFS. Thank you, Dr. Pankaj Talwar, Dr. Shweta, Dr. Loveleen, Dr. Neeru, and Dr. Suhani. Thank you so much.
And
So
thank
we'll
you
be
so
meeting
much.
on the,
Excellent presentation.
yeah.
Thank you for having me here. I really enjoyed it. Thanks a lot.
Yeah. Thank you, Loveleen. Thank you, Nisha.
Thank you,
Thank
ma'am. Thank
all
you.
the young Turks. So be prepared for the next session.
Yeah.
Good job, Suhani.
Good
Thank you.
job. Yeah, really good.
We will have a mentoring session from Dr. Pankaj Talwar sir also for the next Young Turks meet. Thank you. Thank you. Thank you,
Okay.
Dr. Loveleen. Thank you.
Thanks a lot. Thank you, Dr.
Bye.
Nisha. Bye-bye.
Bye.